Hi, my name is Rob Hendrickson. I'm the Program Director for the Fellowship in Toxicology at Oregon Health and Sciences University. And I'm going to be talking today about human milk toxicology, and that is the toxicology associated with breastfeeding. You know, the term I'm using here is human milk. I will probably go back and forth using breast milk and human milk, but it's just an attempt to be a little bit more correct, since all milk is breast milk. Cow's milk is also breast milk. So just specifying here, we're talking about toxicology of a child being exposed to their mother's breast milk. And what my objectives are really to talk a bit about toxicity that can occur in small children. And the reason why I want to talk about that is toxicologists really are asked for really two things. One, determining toxicity or the cause of death in a child that was breastfeeding, and I've certainly had a couple of those consults myself. And then also the more general question is this okay in breastfeeding, and how can we predict whether this is an okay medicine for a mother to take while she's breastfeeding? So that's really the core of why I want to talk about this. And of course, human milk toxicology is in the core content, and it's an important thing for toxicologists to understand. So I'll review lactogenesis, which is the production of human milk, and then talk a little bit about the factors that determine toxicity, sort of the pathway from an ingested medication all the way to, in the mother, all the way to the infant, and the cause and potential toxicity there. And I'm going to use opioids as an example. Probably the most common question that most toxicologists are going to get, either investigating toxicity or a death, or as a general question whether this is okay to use during breastfeeding. So this may remind you, this is a picture of the alveolus, mammary alveolus, and this may remind you of pulmonary alveoli, and they're very, very similar, except, you know, the center, these are sort of spherical structures with a stem that goes and connects them to mammary ducts. But the middle of this is human milk, as opposed to, of course, in the pulmonary alveoli, which is air. But I'm going to try to concentrate on this little section right down here, that if you see, there's the alveolus up above, and then there's a single cell layer, and then there's a capillary. And let's get a little bit closer view of that. And this is from a paper that Nate McEwen and I published a couple years ago. And it really goes through the different ways that things can travel into the milk. And so the first thing that I want to bring attention to is that the mammary alveolus does not have any separate storage vessel. And so the milk that is expressed is always one cell layer from a capillary, and so it really does reflect the amount of the substance that's in the mother's blood at the time of the feeding. There's no human milk does not get produced and then stored away from capillaries. It is always in constant one cell away from capillaries. And so any xenobotic, any medication can travel into the mammary alveolus and also can diffuse back as well. So let me step back for a second. There's a few different ways for substances to get into the milk. Proteins and lipids are produced within the cell and exocytosed into the mammary alveolus and don't participate in drug transfer. All the way over on the right on this screen is something called the paracellular pathway, and that is really xenobotics or medications that are traveling from the capillaries in between the cells, and in general, this can only happen at certain times. So the breast has these cells that do not have a lot of tight junctions most of the time. But once breastfeeding is initiated postpartum, those tight junctions become very tight, and there's no pathway there anymore for any drug to travel out into the milk. There's only two exceptions to that. One is the very first couple of days that you start to have breastfeeding, there can be some xenobiotics that travel through the paracellular pathway. And in one other scenario where you have mastitis, and mastitis may break down some of these tight junctions and allow a little bit of diffusion between the cells in this paracellular pathway. But otherwise, it's really not a very significant pathway. It's probably not a very important pathway for toxicologists, which gets us to the other two. Carrier-mediated transport is the method where certain xenobiotics, particularly things like immunoglobulins, not really xenobiotics and medications, but get transferred actively by binding to a carrier, being endocytosed, traveling across the cell, and being exocytosed. This is not a very significant pathway for drugs and medications. There are some things like nitrofurantoin and penicillin, and ranitidine and cimetidine that travel this way, but are not really very important when it comes to infant toxicity because they're simply not exposed to a tremendous amount of those medications. So while some xenobiotics travel that way, they're generally not that important for toxicology. So that brings us to the last and the one right in the middle, which is plain old diffusion. And that is how most xenobiotics travel from the maternal circulation into the mammary alveolus, into the breast milk. So simple diffusion across the cellular membrane, basal membrane, and then transfer across the cell and diffusion across the apical membrane and into the milk. So as you can imagine, there's many different steps that go through that a xenobiotic would travel through to determine whether it causes infant toxicity. And I'm going to break them apart into 4 different areas. There's some factors associated with the xenobiotic, some factors that are associated with the mother, factors that are associated with the milk itself, and some physical characteristics and chemical characteristics, and then finally factors related to the infant as well. So as far as the xenobiotic, we know what causes things to diffuse across membranes. We can predict it generally if a substance can travel across the membrane. We do this all the time when we talk about traveling across the placenta or a dialysis membrane or the pulmonary membrane. So we know that things that have small molecular weights, that are lipid soluble, and things that have a high maternal free drug concentration would predictably diffuse across the membranes easier. And of course, the determinants of whether the mother has a high free drug concentration would be a small volume of distribution, leaving more of the ingested medication in the capillary, and low protein binding. Because low protein binding increases the free drug fraction and allows more diffusion, since drugs that are bound to proteins don't readily diffuse across membranes. What are the factors that might be associated with the mother? Well, they have more to do with drug metabolism. So something like a morphine or methadone are metabolized by UGT and CYP3A4. So a mother with poor metabolism or a mother with inhibited metabolism might develop an increased free drug fraction or increased free drug concentration of, for example, morphine or methadone if they took another medication that inhibited its metabolism. This is pretty straightforward. Alternatively, some medications have an active metabolite, so increasing the CYP activity in certain cases, either by an adverse effect with another drug or in people who are ultra-rapid metabolizers, for example, CYP2D6, may increase activity if the medication we're talking about is something that is activated by metabolism. So the classic example of this is codeine, which is really a prodrug that gets metabolized to morphine and can accumulate in someone who's an ultra-rapid metabolizer. And more on that issue a little later. Finally, there's physical and chemical characteristics of the milk itself. So the pH of human milk is lower than serum. It's 7.0 compared to approximately 7.4 for serum. So things that are weak bases, things like amphetamine or opioids, can actually accumulate in milk because of ion trapping of those weak bases in the milk. And so you might have a situation where, although it's simple diffusion, the drugs actually accumulate in the milk at higher concentrations than they are in the capillary. The second factor is lipids. The human milk has a lipid content of over 4%, sometimes much higher than that depending on a couple of other factors, whereas the serum has a very low lipid concentration, less than 1%. And so something that's lipid soluble can, while it's only traveling across by diffusion, can actually get lipid trapped and actually accumulate in human milk. And so, again, you may see a situation where even though this is diffusion, the concentration in the milk is higher than the concentration in the capillaries, or at least higher than would be predicted. And finally, of course, there's many factors that, so far I've just talked about things that include the mother and the transfer into human milk, but then that human milk is to be swallowed by an infant and then handled by the infant through many, many different steps before we can develop toxicity, and several other determinants, for example, can be important. For example, absorption. Most of the time when we look up absorption in a textbook, we're talking about a study done on adults with low gastric pH with particular intestinal flora. And both of those things are not present in neonates. The neonatal gastric pH is not the same as an adult gastric pH, and so it's difficult to predict how much the infant will absorb. The metabolism, hepatic metabolism, while things like 2D6 and 2E1 increase rapidly after birth, some enzymes, 3A4, 1A2, UGT, 2B7, have fairly reduced activity for several months, and it takes 3 to 6 months for those to get up to their sort of normal or adult metabolic rate. And so certain medications that an infant might be exposed to that are metabolized by these may have decreased clearance and may accumulate over time. And certainly several of the opioids are on that list: morphine, oxycodone, hydrocodone, methadone, buprenorphine, all metabolized by these enzymes. Clearance is also reduced after birth and takes several months to increase. The body composition of, we're talking about the body fat of a 1 kilo preemie is only 3%, but a full-term baby that's 3.5 kilograms will have 12% body fat. So depending on if you have a fat-soluble drug, it will have a different volume of distribution in an infant or in a newborn that has a different weight based on the body fat composition. So all of these things you have to sort of predict and are difficult to do so. The volume of meals changes over time. The content of breast milk changes over time. How much fat is in breast milk increases as the child gets older. So these are somewhat difficult, and there are some formulas that you can look up that can tell you what the average volume of a meal is based on the infant's size and age. And then one thing I want to note is that we often think about tolerance in an infant, but so especially when it comes to things like opioids, like a mother who's on methadone, that child's been exposed to methadone throughout the whole in utero process and the pregnancy. But we do have to take into account a couple of other things. There are CYP enzymes in the placenta, which sometimes will metabolize some of these medications. So the fetus was not being exposed to as much of a medication as it is when they're a neonate. And then much of the medications in a fetus are actually transferred back out through the placenta, back to the mother for metabolism there. So just because a fetus tolerated exposure to a medication does not necessarily mean that an infant will as well. So can I just look this stuff up? You know, you would think that there would be books and books of stuff that, you know, I know when I practice, I sometimes say, can I give this medicine during breastfeeding? And we look it up, and there's a little chart, or there's some something in a pharmacopoeia that tells me yes or no. But in this case, there are some tools that we can use that are actually somewhat helpful, unfortunately based on really limited data. The first is something called the M to P ratio, which is the milk to plasma ratio. And essentially, you take a mother, you get her, get a sample of her breast milk, and you evaluate it for the xenobiotic. You get a sample of her blood, you evaluate that for the concentrations. You divide the milk concentration by the mother's serum concentration. And what this really is telling us is, if the M to P ratio is about 1, then diffusion is perfect. It just diffused right from the capillary concentration right into the milk, and it's in perfect equilibrium. If it's an M to P ratio that's very low, then diffusion is not that great, or there's another factor that it's poorly transferred into milk. And if the M to P ratio is greater than 1, then that means this is a medication that is accumulating in human milk. And of course, an M to P ratio greater than 1 doesn't necessarily mean it causes toxicity, but it certainly does suggest that it accumulates in milk. More complicated is the relative infant dose, which is really a way to take the dose. It's the infant's weight-based dose divided by the mother's weight-based dose. We're trying to say what percentage of the per kilo dose that the mother took is the child getting exposed to. And what is acceptable really depends on what the medication's purpose is and how important it is, and if it's some medication that would cause toxicity in an infant. But in general, most medications are quite low, less than 1%, and an RID greater than 10% is labeled as should be used with caution, and greater than 25% should not be used in breastfeeding women. And again, these are really general guidelines, but they're good benchmarks to take a look at if you're evaluating a medication. The exposure index is much more complicated. It tries to take into account the milk intake and also the drug clearance. It's likely much more accurate to give an idea about, because it takes into account not just the exposure, but also how much the infant clears. So it takes into account accumulation. Unfortunately, there are a very limited number of medications that have an M to P ratio, even smaller number of medications that have an exposure index. And so these rarely are helpful. It's simply the exposure index is rarely helpful simply because we just don't have that much data. You know, there's lots of things that we have we think we know a bit about. One example is THC. Everyone knows that it makes its way into breast milk, but the M to P ratio is based on 2 women ever in the 1970s. And so that's the amount of data we have. We have 2 samples, and that's the M to P ratio. So we have to take these with a little bit of caution, and one can imagine that there's going to be a lot of variability in these numbers. The last thing, there are some places you can look, and this is a really nice document that was published many years ago by the American Academy of Pediatrics Committee on Drugs. It's called the Transfer of Drugs and Other Chemicals into Human Milk. It is really an attempt to look at medications that are presumed dangerous, or and also to come up with a list of things that are considered safe. I should note that the last time this was published in Pediatrics in 2001. This is not currently an active document by the American Academy of Pediatrics. There are criteria to keep it an active document, and those have not been fulfilled. It has not been redone in less than 10 years. So while this is published, it is not a current American Academy of Pediatrics document. One take-home from this is, because we get this question a lot, I think, is does the xenobiotic appear in human milk? And the answer is almost entirely yes. There's almost no medication that doesn't show up in human milk, but it all depends on how much. The dose determines the poison, and for most things, very little appears in human milk, and the infant is exposed to very little medication. But in general, everything transfers across. If it transfers by diffusion, it's going to make it in there. So some of the things that they say in this document are really helpful to kind of think about, but not too surprising. It turns out that, you shouldn't breastfeed if you're taking a medication that stops DNA from replicating. So a lot of the chemotherapeutic agents and the things that interfere with metabolism are absolutely contraindicated with breastfeeding, which is not too surprising. These don't come up very much for toxicologists. They be more in the world of rheumatology or oncology. Not too surprising, the AAP also in their publication said that all drugs of abuse should be avoided when breastfeeding. Though they listed 5 in particular, all which were associated with either a known effect or concerns about an effect. And again, not surprisingly, radioactive substances are not conducive with breastfeeding, and all of those are listed here. So this is something to consider. Do radioisotopes appear in human milk? Yes, they do. Should we be exposing an infant to radioisotopes? Probably not. So those are contraindicated. So this is sort of, for toxicologists, I think is probably the most interesting of the charts. And this is a list of drugs that were actually associated with toxicity. A couple of them on here are not entirely surprising, but a couple are, and are not necessarily the first things that popped into people's minds when they think about safety in breastfeeding. So acebutol and atenolol, both beta blockers, both have been associated with an infant who was breastfeeding who developed bradycardia and hypotension. And in the case of atenolol, actually acebutol was actually measurable in about 4 of the 7 infants that were studied, and atenolol was identified in milk as well as the baby that developed toxicity. So beta blocker, something to think about, particularly acebutol and atenolol. These don't come up very often for toxicologists, but certainly something to keep in mind. Aspirin was one child who developed significant metabolic acidosis with a pH of 7.22. She's 16 days old. She initially had a ferric chloride test in her urine, which was negative. But then on a second evaluation, her ferric chloride test was positive. So a little confusing, but they did eventually identify salicylates in her serum, which were 24 milligrams per deciliter on the 3rd day of toxicity. So likely higher than that at some point, but hard to say exactly how high. But certainly evidence of an exposure of aspirin through breastfeeding. And then a few more. Phenobarb were associated with sedation in several children. Some of the other ones on the list are notable. So lithium has documented lithium concentrations in infants who are breastfeeding from mothers who are taking lithium. So another thing that transfers fairly well. So similar to this reference, there's another published a couple of years later, another review with a very similar list of medications, a couple of additional medications, but very similar list as well, but just another reference to go to if a case like this comes up. So I want to talk a little bit about opioids because I think this is by far the most likely scenario that we'll be asked about. It's one of the most common medications that breastfeeding women take. And, as I said before, the answer to the question is, are they found in human milk, is almost always yes. But what about opioids that there might be a unique that might be unique about them that might accumulate in human milk and expose the infant. So this too is a table from the publication I mentioned before, I should say. Just a couple of things to note. In the green, I know it's a very busy slide, but in the green box, the first column is human milk concentration. So you can see that the human milk concentrations are a gigantic range, but certainly are identifiable. All of these opioids are identifiable in human milk without question. And then all the way on the right is serum concentration in the infant. Again, mostly fairly low concentrations with some exceptions. So the answer to are opioids found in human milk, the answer is absolutely yes. Do the infants get exposed? Certainly in some cases they do. This is the case of actual opioid-related severe adverse effects. And the details of this table are not that important, but there are a couple things I want to touch on. Just taking a brief look at this, you can notice a couple of patterns here. One is most of these cases are codeine. So the vast majority of the cases of infant toxicity due to breastfeeding in a breastfeeding mother feeding her child are from codeine. So that's the first. The second is you look at the ages, and most of them are very young, less than 1 month in general, which does make some sense. They're taking the highest amount of volume of breast milk per body weight in kilos at that time, and it does seem like that is the highest risk stage. There's a couple of exceptions on here. But if you notice the patterns, these are both older children, but the mother's ingested dose was very, very large. In the one on bottom, the West abstract was the mother ingested 80 milligrams of methadone, became unconscious, and was breastfeeding her 13-month-old while she was symptomatic from the methadone. So these are patterns, mostly, I think the pattern is pretty clear. Codeine, very young children, or a large maternal dose with a symptomatic mother. So those are the sort of red flags, risk factors for opioid toxicity in breastfeeding. So let's look at a couple of these cases, the ones I just had on that table. A couple of those I want to talk about. There's a couple that are famous cases that toxicologists should know about. The first one is a very, very famous case. The mother was prescribed postpartum 60 milligrams of codeine. She became very somnolent on day 2. She was decreased to 30 milligrams of codeine. She was breastfeeding a boy. On day 7, he had lethargy. She continued to feed him, had a couple of visits to doctors, and had, on day 12, a decreased intake, change in the skin color, and then on the 13th day, he was found dead. It's a terribly sad case. They found morphine concentrations in his autopsy, and then the mother had milk from day 10 stored in the refrigerator, and so they tested that and got a morphine concentration on that as well. So what do these mean? Infant blood morphine of 70 nanograms per milliliter. Well, there is some data. One of the few times when there's actually some data available to us. There's a study where it looked at 7 maternal-infant pairs, and those infants' blood morphine concentrations were certainly identifiable, but non-negative, but certainly not anywhere close to 70. And then the milk concentration in that same study, the morphine concentration in this milk was much higher than what had been reported before. So what exactly went on here? Well, if you think about those factors we talked about before, xenobiotic transfer into human milk. So the mother in this case was a CYP2D6 ultra-rapid metabolizer. So she was metabolizing codeine into morphine. That's why she got symptomatic on day 2 and had to cut down her dose. But she was producing a lot of morphine, a lot more morphine per codeine dose than the average person, which explains why there was more morphine in her milk and explains why there was a high concentration of morphine in the infant. In addition to that, while morphine is well absorbed, UGT, which is what we use to metabolize morphine, is fairly immature in a less than 2-week-old. And so another factor, not only was the infant exposed to a lot of morphine, but then it also accumulated because the infant's clearance was decreased. So this has been published in The Lancet, teaches us a little bit of a lesson on what to do when we have these situations. And I've personally been involved in a few sort of similar cases, if we are usually on a hunt for the truth. We're concerned that the child may have gotten into an opioid or may have been given an opioid as an oral ingestion or been exposed to breast milk, and so the best thing to do if we're in this type of situation is to get concentrations from the infant, the mother, and the milk. And if you can do that, then that is something that you should be able to determine what actually happened. And of course, in a situation like this, where this mother might have been accused of poisoning her child with morphine, then you can consider things like genotype analysis for thinking about CYP2D6 or thinking about adverse events from drug interactions. So case number 2 is the case I was involved with and mentioned a little while ago. It's a woman who ran out of her hydrocodone. She takes it for back pain. Her husband also has back pain. He takes methadone, so she took his back pain medicine, which ended up being 80 milligrams of methadone. She started to breastfeed, fell asleep, potentially became unconscious during the breastfeeding, and awoke about 45 minutes later, and the child was cyanotic and not breathing. And EMS was called and administered naloxone, and the child woke up. So is methadone found in human milk? And this was one of those interesting scenarios, and I had mentioned before that the M to P ratio is sometimes helpful, sometimes not. And in this case, not really. It ranges from 0.05 to 1.9. So that's about as wide as it gets from a milk to plasma ratio. RID is relatively low. AAP considers it compatible with breastfeeding. So what happened? If it's compatible with breastfeeding, then what happened? Was this child poisoned with methadone? Did this child find methadone and ingest the methadone? Certainly doesn't seem that way by history. And so what should we do? We should get maternal, infant, and milk concentrations, and we'll try to figure out the truth from there. So the infant blood methadone concentration comes back and is therapeutic. So this is one of those many sort of tricks. What is therapeutic for an infant that is not habituated to methadone? They obtain therapeutic ranges from adults who are taking methadone on a regular basis. So something that comes back therapeutic, while it may be so for an adult who takes methadone on a regular basis, for an infant who has never been exposed to opioids, would be certainly cause symptoms and does seem consistent with the symptomatology. So do we know what the milk concentration of methadone is? And there are a couple of studies with a fairly big range, but certainly helpful. And so what if we got the milk methadone concentration and it was 0? Well, at that point we have to think this child was exposed to methadone not via breast milk. And so either the child found methadone, or the parents gave the child methadone, or there have been cases of older children feeding younger children with methadone or with medications. So more of an evaluation and investigation needs to happen, but this did not happen from breast milk. What if the milk concentration is very high? Well, then it certainly is consistent with the literature that we know. and we certainly would then do the math and calculate how much the child ingested via the breast milk and make sure that the calculation makes sense, but it would seem at that point that it was a breast milk exposure. The last case is a 10-month-old boy. It's an unusual case. Child arrested, a respiratory arrest in a store, and ended up dying, had a postmortem concentration that was exceedingly high of oxycodone. Mom was using oxycodone. The question was this from breastfeeding? This is not always a very easy answer, but let's just look at oxycodone for a minute. Milk to plasma ratio quite high. It accumulates in human milk, both because it's a weak base and because of lipid trapping. There have been studies that looked at oxycodone use in breastfeeding mothers and found milk oxycodone concentrations. And in that study of 50 patients, there was one infant who had an identifiable oxycodone concentration of 7.4 nanograms per mil. So this patient has a serum concentration of 600 nanograms per mil. Now, there may be some issues with postmortem distribution and things like that, but this is really orders of magnitude out of the information that we have. So what if the milk oxycodone concentration is 0? Well, then this child was exposed to oxycodone, but not from breast milk. So either was given or took themselves. What if it's very, very high? Now we have to think, if this is consistent with a breastfeeding exposure, then we have to think about the mother's genotype analysis and whether she is a poor metabolizer or has some other genetic metabolic reason for having such a high milk concentration. So I just want to note one thing. I did mention that codeine was a high-risk agent, certainly when you look at the number of cases that have caused toxicity from breastfeeding. So this was a study that was looking at oxycodone, hoping that oxycodone was a better alternative. They didn't specifically compare oxycodone and codeine, but what they found was that maternal exposure to oxycodone during breastfeeding was associated with a 20% rate of infant CNS depression, as rated by parents. So I think it is important to recognize this, certainly with that question that we do occasionally get, are opioids safe to use in breastfeeding? I think that we have to admit that if you prescribe something like oxycodone, a certain percentage of children are going to have sleepiness related to that, and mothers need to know that so they can keep their eye on that, and also so they can make a educated decision about whether they want to use oxycodone. So to wrap up opioid toxicity in breastfeeding, while clearly millions of women are using opioids during breastfeeding and it has been safe, I think it's important to recognize that toxicity is certainly possible. Mild toxicity is fairly common, and lethal toxicity, although exceedingly rare, certainly is a possibility and something to think about. Personally, what's my advice for breastfeeding mothers who are taking, I see these patients sometimes, and they have an acute event and they need pain medication or desire pain medication, and ask if they should use opioids. I think keeping in mind that 20% of infants infants of mothers who use oxycodone will have CNS depression. You have to tell your patients that. Using alternatives if at all possible, using reduced doses if at all possible. And then I do want to comment one thing, because a lot of clinicians will tell their patients to pump and dump, but I think it's a really, really important thing to bring up, is that if you tell a woman to pump and dump, meaning pump breast milk and then dump it down the drain, not feed it to their child, because of dangers of toxicity, that is a step that is often followed by the mother stopping breastfeeding altogether. And so it's really important. We want to encourage breastfeeding as much as we can, and so only advise mothers to pump and to dump their milk if they're taking large doses of opioids or large doses of something that is potentially harmful, or if it, in a non-opioid realm, if it is truly something that is in the list of things that are toxic to the infant. But then also, as far as opioids go, if the mother gets symptomatic, she should not be breastfeeding at that point. That is when her serum concentration is likely highest, and she's going to expose the child to the most amount of opioids at that point. So, as I was saying, if we ask women to not give that milk to the child, there's evidence that it not only does pumping decrease milk supply in some women, it also may lead to a switch to formula away from breast milk. And also, interesting study done by the Mother Risk program for women who called about an antibiotic and were told that it was safe to take the antibiotic and to continue to breastfeeding, and in fact were encouraged to breastfeed. 7% of them stopped breastfeeding because of that interaction. And so certain percentage, even when told by an expert that it's fine, there's a certain percentage of people who are told to stop breastfeeding temporarily who will simply stop breastfeeding entirely. All right, just one last note. I talked about opioids. The second most common question we get is about ethanol, and so I just want to touch on ethanol for a minute. I'm not going to get into the real details. There's a lot of issues with ethanol exposure by breastfeeding and in utero. I'm not going to get into the big details, but just some general broad strokes, because I do think we get this question a fair amount. So ethanol freely diffuses in and out of the mammary alveolus, and I think that's a really important point. Remember, there's no storage vessel in the mammary gland. Your milk is always one cell layer from a capillary, and so since it diffuses into the milk, it can also diffuse out of the milk, and does. It doesn't get fat trapped. It doesn't have ion trapping. It will diffuse in and out. And so the important note here, I think, is that the ethanol concentration of milk is going to be proportional to the ethanol concentration of the mother at the time of feeding, not at the time a few hours ago, because there's no you don't make milk and then store it. It's always in constant exposure to the blood. And so if the human milk concentration of ethanol is higher than the capillary concentration of ethanol, it will diffuse out of the milk. And so it's the moment that they start breastfeeding, that is the concentration of ethanol that the child would be exposed to. In general, the child's going to be exposed to a small amount. So we're not talking about acute toxicity. There is some evidence of maybe some mild acute toxicity, but if the mother has a 100 milligram per deciliter concentration, and she is essentially going to expose that child to a small amount of ethanol, which is equivalent to about 1/10 of a drink proportionally per kilo. So while it is small, it is still a significant amount, and it is not, of course, starting at 100 milligrams per deciliter, but it is not an insignificant amount. But concentrations that are much lower than that are going to expose the child to much, much lower. And that, again, is the serum concentration at the time of feeding. So there is some evidence of some mild acute toxicity. Infants have slightly decreased PO intake and slightly shorter sleep periods, but from a acute toxicity, it would be difficult to expose a infant to enough ethanol to cause true acute toxicity that is life-threatening and from breastfeeding. So how do I conclude this? Well, again, most xenobiotics are going to be transferred into human milk. So that's the answer. The question, of course, is just like with most questions in toxicology, is just how much. What is the dose of the poison? Is it very, very low, or is it very, very high? There are tools that exist that can help us determine toxicity. And there are certainly several xenobiotics that are associated with infant toxicity, and these may be the things you want to commit to memory and remember. Opioids, benzos and barbs, beta blockers, and aspirin, and there's a few others as well. So don't forget, when exploring a case of possible toxicity, if you can get concentrations of the infant, the mother, and the milk, that should be able to answer your question as to how this child develops toxicity, or if the toxicity was related to that breastfeeding, the xenobiotic in breast milk. So thank you so much. That's all I have. My email is there. If anyone has any questions or comments or ways to improve the talk, please feel free to email me. And I just want to say thank you for your time. Take care.